I would like to thank SAGES for the opportunity to present our work. My name is Heather Carmichael, and I am a surgical resident at the University of Colorado. I will be presenting the results of a multi-center randomized controlled trial in surgical trainees, examining the impact of a hands-on surgical energy curriculum taught via telementoring. I have no disclosures, however, I would like to thank the many collaborators on this project. Most surgical procedures use devices that apply energy to tissue. Although they are perceived as safe, surgical energy devices can result in significant adverse events, including operating room fires, skin burns, bowel perforation, interference with cardiac implantable devices, and mortality. Although ubiquitous throughout surgery, energy devices remain poorly understood by many trainees and even practicing surgeons. In order to address this public health issue, SAGES developed an online didactic curriculum, Fundamental Use of Surgical Energy, or FUSE, in 2012. FUSE is a web-based multimedia curriculum covering 63 learning objectives across 10 domains. Unlike its counterparts, the fundamentals of laparoscopic surgery and fundamentals of endoscopic surgery, FUSE does not have a hands-on component. As hands-on training has been shown to be a powerful adjunct in surgical education, a structured benchtop simulation curriculum based on the FUSE objectives has recently been developed to complement the online FUSE didactics. This curriculum includes 4 modules, a total of 9 tasks, and lasts approximately 1 hour in duration. This benchtop FUSE curriculum has been tested in a randomized control trial with trainees who participated in the hands-on curriculum demonstrating superior outcomes in both knowledge on a multiple choice assessment as well as self-perceived confidence both immediately following and at 3 months post-curriculum. This was again demonstrated in a multi-center trial and a further study looking at outcomes 1 year post-curriculum. While this in-person hands-on training is clearly effective, it can be expensive because it requires an expert proctor to travel and participate in the training on site. Thus, in this study, we wanted to test the hypothesis that the same curriculum delivered via a telementoring model could result in an equivalent outcome. In terms of our study design, this was a 2-armed, multi-center randomized trial. Participants at each center underwent a baseline assessment followed by a 1-hour didactic lecture. Participants were then randomized. The control group participated in the typical benchtop curriculum delivered by a live proctor. The intervention group participated in the same benchtop curriculum with the same hands-on tasks, but with the proctor physically located in a separate room and participating via webcam. All participants were assessed immediately following the curriculum and again at 6 months. Our primary outcome was performance on a previously validated 35-question multiple choice exam. There were 2 versions of the exam. One was used for pre-curriculum assessment and the other for post-curriculum assessment immediately and again at 6 months. Students were also asked to rate their level of comfort in performing 7 electrosurgical tasks, as well as to self-assess their level of competence in the 35 course objectives. Intergroup comparisons were made using a Mann-Whitney U test. Comparisons of pre-curriculum and post-curriculum test scores within each group were made using a Wilcoxon-Rank sum test, with p less than 0.05 considered significant. In comparing groups, we also used a non-inferiority design with an equivalence margin of 8%. This margin was chosen as it represented the smallest meaningful added benefit of the hands-on curriculum over the didactic curriculum alone, based on prior studies. In terms of our study population, the participants across the 3 institutions were 27 to 28 years old and 55% male. Almost all were at the PGY1 level and were trainees in general surgery. 20% noted prior training, whether formal or informal, in the use of surgical energy devices, and 10% had a related undergraduate degree in engineering, math, or physics. There were no differences in baseline characteristics between the randomized groups. However, 10 studies 10 study participants did not complete 6-month follow-up, but these subjects were not different from those who completed all phases of the study. We found no differences in median scores between the groups at baseline. Both groups showed improvement in their scores immediately after the curriculum, but there were again no differences between groups. At 6 months, both groups showed a decline in exam scores, although they were still significantly higher than baseline. Again, there were no differences between groups. Furthermore, results showed that the telementoring curriculum was not inferior to live in-person delivery of the curriculum. In this graph, you can see the difference in exam scores between the live group and the telementoring group. Values on the positive side of the graph, the right, favor the live or the control group, while values on the negative side of the graph, or the left, favor the intervention group. None of the confidence intervals here cross the non-inferiority margin threshold of 8% represented by the dashed line, indicating that telementoring was not inferior to in-person delivery of the Benchtop Fuse curriculum. In terms of self-assessment, participants in both groups rated themselves as either very uncomfortable or uncomfortable with all 7 electrosurgical tasks pre-curriculum. After the curriculum, participants felt comfortable with 6 out of 7 tasks. In terms of competence with the 35 course objectives, participants felt partially or fully competent with only 1 out of 35 objectives before the course. After the simulation curriculum, they rated themselves as partially or fully competent with 34 out of 35 objectives. There were no differences between the live and telementoring groups in these results. In conclusion, we find that Benchtop simulation is a valuable hands-on addition to the Fuse curriculum that improves knowledge of electrosurgical devices and is superior to the didactic curriculum alone. The curriculum can be effectively delivered using a telementoring model with a remote proctor who's an expert on the material. This model can reduce costs of the hands-on program and make it more widely available, including for international audiences.